Okay, welcome everyone. I think we'll get started now. If you're still trickling in, feel free to just listen in. So welcome. Thank you for joining us for today's webinar on the advancements of care for triple-negative breast cancer. I am Rebecca Armstrong. I'm the Manager of Patient Education Programs with the Canadian Breast Cancer Network. Before we get started, I'd like to cover a few housekeeping details. This session is being recorded and will be available on our website for anyone who may have missed it, and I'll send out the link once the recording is available. You'll also find previously recorded webinars that address a variety of breast cancer-related topics on our websites. I would like to extend our sincere appreciation to our sponsors for the session, who've provided support through our unrestricted educational grants: Novartis, our gold level sponsor; Gilead, our silver level sponsor; and Pfizer, our bronze level sponsor. The format for today's session will be a presentation followed by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using the Q&A function that should be located at the bottom of your screen. And I'd now like to welcome our host for the session, Kathy Amendolia. She's the chair of the board for the Canadian Breast Cancer Network.
Thank you, Rebecca, and welcome again to everyone. Thank you for joining us today. I'm very pleased to welcome and introduce our expert speaker, Dr. Terry Ng, a full-time medical oncologist at the Ottawa Hospital Cancer Centre and assistant professor at the University of Ottawa. Dr. Ng is also a clinician investigator affiliated with the Ottawa Hospital Research Institute. His practice is primarily focused on treating patients with breast and brain malignancies, but he has been interested in finding ways to treat and support cancer survivors, especially those diagnosed with more difficult to treat cancers like triple-negative breast cancer. We are incredibly appreciative of all the time that Dr. Ng offers to the patient community by joining us today. Dr. Ng, it's great to see you, and thank you for being here.
Thank you so much for the kind introductions, Kathy and Rebecca. I'm just going to take a second to share my slides. Okay. Can everyone see my slides properly? Perfect.
Yes.
So, so here are my disclosures, just briefly. But as a disclaimer, today's talk will reflect my own biases and opinions and interpretation of the data. There is too much data out there, so I will try to cover only what I think are most impactful for patients today. So my goal today is to empower patients and caregivers to kind of understand the principles of how we think about the treatment of early and metastatic triple-negative breast cancer, and to provide some information from practice-changing clinical trial data for patients with this disease. So many of you know, but some of you may not, triple-negative breast cancer is a subtype of breast cancer, about 10 to 15% of all new breast cancer diagnoses, that is really simply defined as breast cancer cells that do not express estrogen receptor, progesterone receptor, or HER2 protein marker. So really, it's a complicated disease beneath the surface. This is just to show the general breakdown of the prevalence of the different subtypes of breast cancer. And you can see on the left-hand side, by far the most common are hormone receptor positive, HER2 negative breast cancers, followed by comprising about 70% to 75% of patients, followed by HER2.
Sorry, Dr. Ng. I'm having trouble. It's not switching through the slides, so I'm not sure if it's doing that for others, but for me, it's not switching through the slides yet.
Oh. I might just have to do it without presentation mode then. I don't know if that's ideal.
There we go.
Can you see the slides now?
Yes, I can see the slides now.
Okay. And can you see me move into the next slide?
No.
Okay. I
Oh.
will,
Yeah, you might just have to switch manually between each one.
okay, I'll work with that. So I just need to. All right. So this is just to show that on the far right, triple negative breast cancers consist of about 10 to 15% of all breast cancer patients. And when you look at the division of prevalence by ethnicity, unfortunately, I couldn't find very kind of easily presentable Canadian data, but this is US data showing that by far, in the US at least, non-Hispanic Black patients have a much higher risk of triple negative breast cancers, followed by other ethnicities. And here's some data about the age distribution. Generally speaking, triple negative disease is a disease that impacts younger patients more often than older patients, but certainly we can see triple negative breast cancer being diagnosed across all spectrums, all parts of the spectrum, age spectrum. So kind of the important pieces of information that we know about triple negative breast cancer is that it's much more aggressive and that patients tend to do more poorly compared to quote unquote non-triple negative breast cancer, so meaning that ER positive or hormone receptor positive and HER2 positive patients. And on the top two survival curves, you see in the yellow line that the triple negative patient survival rate is lower than the non-TNBC. And then the other take-home point, if you look at the bottom two figures, is that the risk of relapse after a diagnosis of early stage triple negative breast cancer is in the first 3 to 5 years. And so the risk of disease recurrence or death after 5 years improves significantly if nothing happens in the first 5 years. So I'd like to guide our discussion with a case. So this is Miss Smith. She's a 38-year-old woman, premenopausal. She has 2 young daughters. She's been breastfeeding her younger daughter, who's now 12 months old, and up until recently felt a lump in her left breast. And so she went to her doctor, who sent her for a mammogram, which showed a 3-centimeter mass in the left breast, upper outer quadrant, as I've marked here in the picture, and also possibly an enlarged lymph node underneath her armpit. And so she was sent for an ultrasound-guided biopsy, which unfortunately showed a high-grade invasive ductal carcinoma, which is 70% of invasive breast cancers, and the markers came back ER negative, PR negative, HER2 negative, which we call more commonly triple negative breast cancer. And so her surgeon sends her to medical and radiation oncologist for consideration of neoadjuvant therapy. So what is neoadjuvant therapy? Well, there's neoadjuvant therapy and there's adjuvant therapy. And as you can see in this kind of simple diagram, basically neoadjuvant therapy means we're trying to give medical therapy before surgery with the intent to cure a disease, whereas adjuvant therapy in the cancer context refers to surgery first, followed by chemotherapy. And for the longest time, both neoadjuvant and adjuvant approaches were considered comparable in terms of survival outcomes. And so I'll just show you the data that backs that up. Essentially, these two curves shows breast cancer mortality and all-cause mortality. And you can see in the red and the blue curves representing neoadjuvant and adjuvant therapy that they almost overlap. So no difference in breast cancer-related deaths or death from any cause. And over here on the right-hand figure, I'm sorry, the text bar shows up. This was supposed to be an animated thing. But essentially, you can kind of see that on the right, which looks at risk of distant metastases, there was no difference between the red and the blue curve. Okay, but there is a slight increase in the risk of local recurrence in terms of patients who got neoadjuvant therapy. But wait, this was actually not just data from one study. This is what we call a meta-analysis, which combines data from dozens of studies, right? Representing data points from 4,800 patients. And so they did a breakdown of studies that were included, over 4,000 patients, where definitive curative intent surgery was used on the left-hand side, and showed that, in fact, there were minimal differences in the local recurrence rate between neoadjuvant and adjuvant approaches, whereas the studies that less commonly, for whatever reason, achieved surgical resection showed a huge difference in local recurrence rates, favoring adjuvant treatment or upfront resection. So perhaps it's patients who never even got surgery, and for that reason that we're seeing some increased rates of local recurrence in this meta-analysis. So essentially, for the longest time, both approaches were acceptable. However, really, we would used to do neoadjuvant therapy, so chemotherapy before surgery, for the following reasons. A would be to make a tumor that was previously unresectable but not yet considered metastatic or stage 4, to try to make that resectable by giving chemotherapy to shrink it. So examples would be tumors that are fixed to the chest wall, or if there were lymph node masses that were fixed as well, not mobile, those would generally be considered unresectable upfront. The other reason would be to potentially make it a possibility for someone who was originally destined to have a mastectomy, a full breast tissue removal, to have a chance of being able to have a lumpectomy, a partial breast tissue removal. And more recently, potentially, we can now convert someone with node-positive disease upfront if they had a very good response and all the lymph node metastases were obliterated by the neoadjuvant chemotherapy. It may be deemed acceptable nowadays to omit a full axillary lymph node dissection, which, as some of you may or may not know, can be quite morbid. So, and the final reason is neoadjuvant therapy allows us the luxury of assessing how well the tumor responded to the chemotherapy. Whereas if your surgeon removes the tumor up front, we don't really get to see that, and we don't have that information. And this is has become infinitely relevant, as I will show you soon. So there's a concept of pathologic complete response after preoperative chemotherapy or neoadjuvant therapy. This data basically shows you comparing survival outcomes between triple negative and non-triple negative breast cancer, that even if they had triple negative breast cancer in the blue curve, that if they had, as long as they had a pathologic complete response, their survival outcomes are very comparable to someone who had a non-triple negative breast cancer. And as you can recall a few slides ago, those patients tend to do better with a 5-year survival rate in the low to mid 90s, right? Whereas if you had residual disease, or what I'll call in future slides, non-pCR, patients do worse, especially if they had triple negative breast cancer. So that's very important. And just to further clarify, PCR refers to when the surgeon removes the tumor from the breast and the pathologist looks at the breast tissue under the microscope and sees no residual invasive cancer cells. That's what we mean by a PCR, or pathologic complete response. And so going back to our case number 1, the surgeon sends the patient to Mrs. Smith to neoadjuvant therapy, and the medical oncologist recommends that because of the risk of their disease. And so traditionally we would give anywhere from 4 to 6 months of chemotherapy, and then they see their surgeons. And then after surgery, we would then have the information about whether or not the patient had a PCR or a non-pCR. And just as a little bit of background that will be a little bit important in a future slides discussion, the standard chemotherapy that we're offering nowadays includes a class of drugs called anthracyclines, usually for 4 to 6 cycles, followed by a class of drugs called taxanes, typically something called paclitaxel or docetaxel for 3 to 4 cycles. And sometimes we add an extra drug called carboplatin, just to give us a little bit of extra bit of power to hopefully increase the chance of achieving a PCR. And here I in the bottom of the slide, I again define what those mean. Key update for patients with early stage triple negative breast cancer was in 2002 when a study called KEYNOTE-522 tested whether adding immunotherapy to chemotherapy starting from the neoadjuvant time point, so pre-surgical treatment, would improve outcomes. And they did. So this basically summarizes that and shows that when you add this immunotherapy drug called an immune checkpoint inhibitor called pembrolizumab to the standard chemotherapy that I just described, that both the risk of disease relapse and the risk of death significantly increased. And this is just data from longer follow-up. We see that there was a 9% improvement in 5-year disease-free survival from the addition of pembrolizumab to chemotherapy prior to surgery, and the protocol mandated that patients also continue pembrolizumab alone for up to 6 months based on tolerability. And so let's say the best case scenario, patient does that treatment and has a PCR, yay, and they just continue with up to 6 months of pembrolizumab. And so the data from the KEYNOTE-522 study showed that irrespective of whether or not they got pembrolizumab, as long as the patients that got PCR seem to have very good outcomes, right? Like the survival curves, the blue is, sorry, I guess the teal color is 94.7% is pembrolizumab plus chemotherapy, and the purple line is 92.6% 3-year disease-free survival, which denotes placebo plus chemotherapy. So there's an ongoing study right now that's enrolling in the US mainly, I believe, that is asking the question, well, what if patients got a PCR? Do they still need an additional 6 months of therapy, or is that sufficient? And that's an important question because all treatments have the risk of some toxicity and side effects, and immunotherapy in particular, there's about a 10% risk of developing severe or even life-threatening side effects. So cutting unnecessary treatment short is a terribly important question for our patients. And then beyond looking at whether or not someone had residual disease or a non-pCR, studies have shown that if there's a spectrum of how much residual disease a patient can have, right? So someone can have minimal response, which is noted as residual cancer burden 3. They can have an intermediate response to neoadjuvant chemotherapy, marked by RCB2. They can have very good response, but not quite a complete response, denoted by residual cancer burden 1. Or they can have a pathologic complete response, denoted by RCB0. So as you can see here, on the horizontal axis is time, the vertical axis is the percentage survival. It's very clear here that if you have a pathologic complete response, you do much better than someone who had RCB1, 2, or 3 disease. So let's look at a second scenario for the same patient, got chemoimmunotherapy and went through surgery. Essentially, there's a lot of text, I apologize, but this is just to show that this was their pathology report. And it basically showed that they had a minimal response, residual cancer burden 3. So definitely a non-pCR. So the question is, what can we do for these patients? And so in 2017, actually, there was a Japanese and South Korean study called CREATE-X that was a randomized study that essentially showed fairly convincingly that if you escalated treatment by giving additional chemotherapy for up to 6 months, that you can potentially improve their survival. So this is in the blue on the left-hand figure. In the blue curve, capecitabine improves the risk of disease relapse or death by about 42%. And it also improves overall survival by about the risk of overall survival by about 48%. And so capecitabine it's a chemotherapy pill, and it's commonly used in patients living with breast cancer. And this was because of how challenging it is to kind of manage patients with non-pCR response due to their risk of recurrence. Despite the absence of North American or Western European data replicating these findings, we've essentially adopted this practice of using capecitabine if someone had residual disease after neoadjuvant chemotherapy. But wait, how do you reconcile using immunotherapy, which kind of came into our realm just a few years ago, and the data from capecitabine, which was published several years before that? It's important to note that the immunotherapy study, the KEYNOTE-522, didn't allow patients to get capecitabine if they had non-pCR, and that was mainly because that data wasn't available yet. It was not yet the standard of care at the time. So we're at an impasse where clinicians they're not really entirely sure what's the best approach, and it's a constant area of debate. And furthermore, at least in Ontario, drug access to use the combination is an issue. So some potential options would be to combine the two, so pembrolizumab plus or minus capecitabine, and it's not routinely funded in Ontario. Patients with private insurance may be able to access this doublet treatment, or we could elect to choose one or the other monotherapy, or we could enroll a patient onto a clinical trial. So this patient received, after surgery, 5 weeks of radiation to the breast and their lymph nodes. And they also started capecitabine chemotherapy pills for up to 6 months. And just for argument's sake, they were able to access pembrolizumab through their private insurance. Nonetheless, we know from the immunotherapy KEYNOTE-522 study that if you had residual cancer burden 3, that your outcomes generally were pretty poor. The 3-year disease-free survival in the pembrolizumab arm was 26%, and the placebo arm plus chemo was 34.6%. I wouldn't compare the numbers. It's not that getting pembrolizumab will lead to worse outcomes here because the number of patients are too small, and it's a kind of a subgroup analysis, but it's just to demonstrate that it makes like if you have an RCB3 response, then it's high risk. Okay, so what we don't really know yet is how important is giving immunotherapy after surgery. So going back to if you've given it before surgery, you need to give it after surgery. But what about giving immunotherapy if someone had upfront surgical resection without prior treatment, without prior chemotherapy or immunotherapy treatment? So this is a study run in the US where they are looking at that question. Patients who had chemotherapy alone, who had residual disease after surgery, and are randomized to receive pembrolizumab, which is the immunotherapy drug, for up to 1 year, or observation alone. It's completed accrual, but no results yet. At San Antonio Breast Cancer Symposium in December of 2023, this was a European study where they gave did surgery up front, followed by chemotherapy plus a different immunotherapy drug called atezolizumab. And once patients completed their chemotherapy, they got another 6 months of atezolizumab. And what you see here is there was completely no difference in invasive disease-free survival, and statistically it was deemed that the treatment was futile. And so for that reason, I think our way of thinking about the importance of adjuvant immunotherapy is starting to shift. Although the limitations of applying this data to the pembrolizumab data is that it's a different immune checkpoint inhibitor. It's not the exact same population. So, but this is giving us some signal about, well, if you don't have the tumor to kind of alert the immune system to act on the tumor after surgery, then immunotherapy may be less effective. So let's go back to Ms. Smith again to highlight a third possible scenario. So they get chemoimmunotherapy, and because they were under the age of 60 and because they had triple-negative breast cancer, they were referred for genetic testing. Lo and behold, they tested positive for something called a germline BRCA1 mutation. Because of that, they had a bilateral mastectomy, so both breasts were removed, and also lymph nodes were sampled, and they had a residual cancer burden 2 score. So partial response, so still non-pCR. So in this situation, what would you do? So patients with a germline BRCA mutation who have high-risk disease, meaning residual disease after neoadjuvant therapy, would qualify for 1 year of olaparib. So where does that come from? I'll show you the data. So some of you may or may not know that amongst triple-negative breast cancers, about 15 to 20% of patients have what we call germline mutations. So these are genetic changes that are inherited in all of your cells, not just your cancer cells. And the importance of this finding is that your lifetime risk of breast cancer and other cancers may be increased or significantly increased. If you had BRCA1 mutation, for example, there's a 70% association with triple-negative breast cancer. If you have BRCA2 mutation, there's about a 30 to 40% association with breast cancer, both triple-negative and ER positive and other subtypes, and also a higher prevalence found in men. So the 1% of breast cancer patients who are male are more likely to have a BRCA2 mutation. And then you have a smattering of over a dozen other germline mutations with varying importance and implications for other cancer risks. And so olaparib, which I mentioned 2 slides ago, is a class of medications called a PARP inhibitor. They are important in patients that have this thing called homologous recombination repair deficiency, so HRR deficiency. So having a germline BRCA mutation is an example of that. Those people have HRR deficiency. So it's kind of a double hit thing, what we call synthetic lethality. So PARP is a molecule that interacts inside your cell that can repair single-strand DNA breaks. So our DNA is comprised of two copies, right? 2 double strands, or rather they're double. We call it double-strand DNA when they're intact. So when you have HRR deficiency, the kind of partner mechanism for repairing DNA doesn't work, and so when that happens, and you inhibit PARP, which prevents those single DNA strand repairs, you have what's called synthetic lethality, and your cancer cell is more prone to dying. Whereas if it was a normal cell without that deficiency, then it's more prone to self-repair. And so the Olympia study was a landmark study that was presented 2 years ago, I believe, at ASCO, where they showed that where they enrolled patients with germline BRCA 1 or 2 mutations with triple negative breast cancer or HER2 negative ER hormone receptor positive patients. But I'll only focus on the triple negative breast cancer cohort. And so there was one group where patients got neoadjuvant therapy and had residual disease or non-pCR. They were randomized to either receive olaparib for 1 year or placebo for 1 year. And the other group was were patients who had upfront surgical resection, who had, based on pathology, what they called high-risk disease, and kind of went through the same process of one-to-one randomization to the pill twice a day for 1 year or placebo pill twice a day for 1 year. And so here are the results from that study, basically showing a 7.3% improvement in 4-year invasive disease-free survival, a 7.4% improvement in 4-year distant disease-free survival, and a 3.4% improvement in 4-year overall survival rate, which is really what we look for as a gold standard metric to adopt a new therapy into practice for early stage disease, because we're not only just trying to reduce the time to relapse, but also ensuring that our treatments are actually prolonging people's lives. And if it doesn't do that, then there's more debate about whether a new treatment should be adopted into practice. And so here is what I would say is a simple diagram of the algorithm so far on how I would think about the treatment of early stage triple negative disease. So at the top is if someone had a small tumor, so generally less than 2 centimeters or less, it would be considered acceptable to have the surgeon remove the breast tumor and do a lymph node sampling. And then usually most patients will end up getting chemotherapy, usually anthracyclines with cyclophosphamide every 2 weeks for 4 cycles, followed by the taxanes every 2 weeks for 4 cycles. And then if they were considered high risk, as per the Olympia study I just showed you, and had the germline BRCA mutation, then they would also qualify for olaparib up to 1 year after chemoradiation. At this point in time, there's no role for capecitabine or pembrolizumab if we did the upfront surgical approach. And for that reason, for most of our patients, especially patients who present with tumors that are greater than 2 centimeters, even if they were node negative, or if they have even a single positive lymph node, would qualify for neoadjuvant chemotherapy plus pembrolizumab. Okay, and just as an aside, you know, I've treated patients with a 1.5 centimeter triple negative breast cancer using neoadjuvant approach. I would just give them the same chemotherapy as I would after surgery without the pembrolizumab because it's not funded. And then I look at what response they got after surgery, and I would make a decision with my patient about what approach. So if they had a PCR, generally most people would do the pembrolizumab if they got pembrolizumab up front for 6 months, or if they only got chemotherapy, it would just be observation. But kind of the meat of it is that if a patient had residual disease or non-pCR, it would be one of these options listed. And so for the future, I think potentially practice-changing trials that are coming about would include the Optimize trial, which I had alluded to. Can we stop pembrolizumab if someone had a PCR after neoadjuvant chemo immunotherapy? There's the Kappa trial, which basically, I don't know if it's open yet, but I found it on clinicaltrials.gov. And the question is, does adding capecitabine, which improves survival in Japanese and Korean patients, to pembrolizumab improve outcomes if patients had residual disease? There's the ETNA study, where patients with small tumors and who had surgery up front, can we omit chemotherapy altogether in patients with expected good prognosis. So I don't really cover this, but basically there's some preliminary clinical data, like in cancer patients, breast cancer patients, where if the tumor sample has very high levels of tumor infiltrating lymphocytes or tumor infiltrating immune cells, that in and of itself predicts a better outcome. Okay, so the Dutch have treated a number of patients without chemotherapy based on their local practice, and then analyzed this stuff and found that it can happen. And then finally, this is an industry study, TROPION-Breast04, where they're asking whether a novel chemotherapy agent called an antibody drug conjugate plus immunotherapy can replace our current standard of anthracyclines and taxanes plus or minus carboplatin. They designed it kind of smartly because even if patients did not get a PCR, patients can opt in to get their standard of care chemotherapy after surgery. So it doesn't necessarily become a deterrence for patients to take part in the study because they, in the end, still get the option to get everything. And then, yeah, I'll kind of go through this very quickly, but essentially, there are other kind of combination treatments that are being tested for patients with non-pCR patients. For example, TROPION-Breast03, we have open in Ottawa and Montreal and Toronto and other sites that are, again, looking at an antibody drug conjugate called Dato-DXd plus or minus immunotherapy in patients who would otherwise get capecitabine or capecitabine plus pembrolizumab if they had non-pCR. And then kind of real world practical questions, like how frequently we should give our chemotherapy backbone. You know, it's a little bit more nuanced. I'll just skip over this. I can go back to it just in the interest of time. Yeah, so this is the same thing. So I just wanted to cover circulating tumor DNA as well, that and beyond looking at residual cancer burden, there are studies, ongoing studies looking at circulating tumor cells and circulating tumor DNA, which are more sensitive ways of detecting microscopic residual disease through a blood sample. And here are two studies that show some impressive data suggesting that if you have a negative circulating tumor DNA sample, especially if on repeated time points, then your long-term outcome of having disease-free survival is very good. Whereas if you have even one positive sample with measurable circulating tumor DNA, then your risk of relapse is much higher, highlighted by the yellow curve on the left. And then Dr. Bassick and his group in Montreal have presented this data a few times in the cohort of almost 60 triple-negative breast cancer patients, looking at circulating tumor DNA just before surgery. And they found that there was a significant prediction of if you have negative disease, then you have very good life expectancy and relapse-free expectancy. Whereas if you had positive ctDNA, patients tend to relapse fairly quickly. So I'd like to move on to case number 2. Mrs. Jones was originally diagnosed in December 2019, and she was treated with neoadjuvant chemotherapy without pembrolizumab, and then had surgery and had a partial response, and then had 6 months of capecitabine. But essentially 3 years later, she presents with increased fatigue, decreased appetite for 4 months, and more difficulty breathing and chest discomfort for 1 month. And here's the CT scan on the right-hand side showing some fluid in the right lung and multiple tumors in the liver, including a large one on the left-hand side. You can see that. And they got a biopsy of the largest liver tumor, which unfortunately showed high-grade invasive ductal carcinoma, triple negative. And so they did an additional test called the PDL1 score, and it came back as 15% out of 100%. So this is important for metastatic patients because some of our treatments now dependent on this marker for us to access these treatments to predict whether or not the chances of working. So there was a study called KEYNOTE-355, which enrolled patients with metastatic or unresectable triple-negative breast cancer. These can be newly diagnosed or recurrent cancers, as long as they were more than 6 months from completing curative treatment. And patients received chemotherapy or immunotherapy or chemotherapy alone. And essentially, they showed there was an improvement in overall survival. And with the addition of pembrolizumab also increased the chance of tumor shrinkage or tumor response, 52.7% versus 40.8%. And I forgot to say that the average survival on this first-line study was 23 months with chemoimmunotherapy versus 16 months with chemotherapy alone. Unfortunately, I mean, she did have improvement. Mrs. Jones did have improvement in her symptoms for 8 months after starting this chemo plus pembrolizumab, but unfortunately developed new liver metastases, and her medical oncologist recommended something called Sacituzumab govitecan. So this is a different antibody drug conjugate. So just to be a little bit more detailed about this, an antibody drug conjugate is really just smarter chemotherapy. They use a large protein, like this Y-shaped protein molecule called an antibody that's normally produced by your immune system, but they've repurposed it to hone in on an address label, whatever address label they want to design it for, right? So triple-negative breast cancers have overexpressed this address label called TROP2, and this antibody drug conjugate basically has chemically linked chemotherapy molecules, and they get preferentially delivered to triple-negative breast cancer cells that have the TROP2 marker and get eaten up by the cancer cell, and they release the chemotherapy on site. So basically a way to give more chemotherapy with fewer side effects and hopefully better long-term efficacy. And this is just to show that triple-negative breast cancers overexpress TROP2 in 96% of patients, and almost 90% have a moderate to strong expression of this marker. And this is a busy slide, but essentially showing you the main study called the ASCENT study that tested and proved this drug, Sacituzumab govitecan, in patients that had pre-treated triple-negative breast cancer, like in the case example I'm talking about, Mrs. Jones. And essentially, this drug was approved by Health Canada because of a significant improvement in overall survival. The median overall survival of patients on this study was 11.8 months versus 6.9 months. So you may notice that these numbers are lower than in the previous study, the KEYNOTE study. That's because patients enrolled on this study had received multiple prior treatments potentially, and so they only counted the time from when they started on this treatment until the time of death. But essentially, this new drug improves the risk of death and the risk of disease by over 50%. And so on this drug, Mrs. Jones had stable disease for 6 months, had some fatigue and diarrhea, but she was able to manage it and live her life. Unfortunately, more and growing liver metastases occurred, and so her oncologist proposed a phase 1 clinical trial of a new antibody drug conjugate called Dato-DXd, which I did actually allude to earlier when I talked about early triple-negative disease. So this is a novel treatment option for patients. It's not only being tested in kind of second and third line setting, but also now in the first line setting. But for the purpose of this case example, I'm just using this as a way to bring this out. Dato-DXd, similar concept. It also uses an antibody to deliver chemotherapy to TROP2, but it uses a different type of chemotherapy molecule. Kind of similar mechanism though, an important thing is this molecule or this drug was designed to have a bystander anti-tumor effect. So not only does the chemotherapy get delivered to TROP2 overexpressing triple-negative breast cancer cells, it was also designed for the chemotherapy to diffuse to adjacent bystanders to hit those cancer cells that may or may not be overexpressing TROP2. And so in this phase 1 study, heavily pretreated patients, 34% of patients had significant tumor shrinkage, which we call an objective response. And an additional 39% of patients had at least stable disease. So this bar graph, each bar is an individual patient. So if the bar is sticking upwards, that means they had some growth in their tumor measurements from baseline. If the tumor bar is pointing down, it means some element of size shrinkage. And this is just a busy graph, but shows that most patients had at least some initial response for variable durations, but some with longer term durations up to 8 or 9 months at least, and possibly ongoing. And some of the common side effects of this drug will include nausea, mouth sores, vomiting, fatigue, some hair loss, and dry eyes. So kind of back to a different case scenario for someone who now has metastatic recurrence. So remember Miss Smith, which I talked about very beginning of this presentation, the one who had RCB3 response to neoadjuvant therapy. Unfortunately, 14 months later, she developed bone pain and abdominal discomfort. The scan showed bone and liver metastases, and the biopsy confirmed the diagnosis of triple-negative breast cancer. Because she had pain in her back from her bone mets, she saw a radiation oncologist, and they gave her a fraction of radiation for symptom relief and also to reduce the risk of fracture. And her oncologist also started her on a bone modifying agent called Zometa or zoledronic acid or zoledronate once every 4 weeks initially to reduce the risk of bone complications as well. And because this patient had previously received pembrolizumab, she was not eligible for first-line pembrolizumab and chemotherapy because that was not studied. And so instead, she received 1 line of chemotherapy with the goal of opting for Sacituzumab govitecan if her first line of defense stopped working. The other options would have been trying to find a clinical trial for this patient. And so, for example, in Ottawa, we have a few clinical trials testing these newer antibody drug conjugates with or without immunotherapy. And there may be also some other trials out there where they're using basket trials to direct specific types of treatments based on the molecular subtype of triple-negative breast cancer. And so this is just to show that these antibody drug conjugates are potentially promising, because in the newly diagnosed setting, the response rates are even higher than chemotherapy plus pembrolizumab. Here in this study of triple-negative breast cancer patients, the response rate was 73.6% with this antibody drug conjugate plus immunotherapy, durvalumab, as opposed to the chemotherapy plus pembrolizumab. And so we realized we've known for probably over almost 2 decades now that triple-negative breast cancers are not all the same. if you did gene and protein and mRNA expression, you can slice and dice them into different biological subtypes. And there have been international efforts to try to find specific targets or ways to attack these different subtypes of cancers. And so this was presented at ASCO last year, American Society of Clinical Oncology. It was a phase 2 randomized study, not very big, but they split the triple negative patients into 4 subgroups. Androgen overexpressing on the left, immunomodulated on the second column, immune suppressed on the third pink column, and mesenchymal subtype on the fourth column. But the largest cohort were the middle two. And basically, using kind of combination targeted treatments, their data suggests that it's better than chemotherapy, like traditional chemotherapy approach alone. So this data looks very good, but it is a selected population. So certainly larger studies need to be conducted outside of China and other countries. And then I wanted to take the last few slides to address the concept of something called HER2-low. So remember in the very first slide, we talked about triple negative breast cancer being hormone receptor negative and HER2 negative. So there's this very specific criteria to call someone HER2 positive, but below that threshold, there's actually, somewhere between HER2 0 and HER2 low, or HER2 intermediate, if you will. So this concept has become incredibly important in oncology now, because there are now antibody drug conjugates, for example, that target and have been shown to be effective in HER2-low cancers, including what we used to call triple-negative breast cancer subtypes. So up to 50% of all breast cancers can now be recategorized as HER2-low patients, including, like I said, hormone receptor ER-positive and ER-negative breast cancers. In this Austrian study, just as an example, 32.5% of triple-negative breast cancer patients could be considered HER2-low. So it opens up some options for our patients. So Trastuzumab DXd or TDXd, some of you may have heard of this drug being called Enhertu, is on the market and is available as part of our standard of care for some of these HER2-low patients. And again, similar antibody drug conjugate concept, but this time the antibody is targeting HER2 overexpressing cells. And the large randomized study basically showed a significant improvement in progression-free survival and overall survival. Note that most of the patients on the study had hormone receptor positive disease, and a subgroup of less than 60 patients had triple negative breast cancer disease. But in this small cohort, we could still see a clearly visible difference on the survival curves. Median progression-free survival from TDXd is 8.5 months compared to 2.9 months with physician's choice. And overall survival was 18 months favoring TDXd versus 8 months with physician's choice chemotherapy. The other kind of important aspect to know about some of these drugs is that we now see that they have effectiveness in brain metastases as well. For the longest time, the blood-brain barrier has been called the unbreakable barrier. And so we are now seeing effectiveness on brain metastases. It's a sorely understudied area, but some of these antibody drug conjugates like TDXd are showing some promise. And just to show that in the blue bars, which are the TDXd treated patients, and the gray bars, chemo treated patients, these are all patients with asymptomatic brain metastases that there's a higher frequency of response and increased duration on average of response. And then before I finish, the final kind of topic to address is really, well, with all of these newer antibody drug conjugates, what are the chances of trying a second one after a patient progresses on the first one? So at the recent San Antonio conference in December, there were multiple posters looking at this question and in a small number of patients. So we don't really have any conclusions, but essentially the take-home message is that once you've tried one, even if you switch to a different one, the chances of it working are less, and the duration of effectiveness is shorter. So it's definitely something to be decided upon on a case-by-case basis. And so this just summarizes for metastatic disease. Triple-negative breast cancer disease, we should always consider clinical trials to not only improve the science and improve care for future patients, but also as a mechanism to access novel treatments for our patients, because the more lines of defense that we have, the more chances of long-term survival. But if we're only talking about standard of care, we need to check the PD-L1 score, and then chemo or no chemo plus immunotherapy if the PD-L1 is high, or chemotherapy alone if the PD-L1 is low. If a patient has the germline BRCA mutation, then we would think about PARP inhibitors like olaparib. And then second and third line, we're thinking about antibody drug conjugates. The only one that's Health Canada and FDA approved right now is Sacituzumab govitecan. At least only one that's Health Canada approved. I won't talk about the US or Europe. And then clinical trials and other novel treatments. I hope I didn't miss anything, but I'd like to thank the Canadian Breast Cancer Network for organizing this event and for the opportunity to speak. And thank you so much for your attention.
So I want to thank you, Dr. Ng. That was a great presentation. And I'm sure I can share this opinion of saying that it's good to see, and it's encouraging to see how much work is being done at all levels to have some good breakthrough to finally get to something like the HER2 positive patients were before the HER2 drugs came along. So those are the things that patients and our groups keep, looking for. So I want to thank you and everybody involved in doing all this great work. Before I read you some questions submitted, I have a couple of questions to start off. In terms with your early slides, you say neoadjuvant first or after, the surgery, what is being done currently and what the difference is. My question is patients and their side effects and their quality of life. So if you do neoadjuvant therapy, some of those therapies we all know can be quite exhausting and quite take over your life. How does that affect a patient to do the surgery after? Like, what does that do to a patient? Because surgery in itself also presents with many different things, not all the time, but you can have lymphedema, you can have other stuff that you're already tired from the therapy.
Yeah. So I think the trend is now that we're giving more and more neoadjuvant treatment, just because we get to assess the response, and also because we have that backup plan on hand if patients have residual disease, right? But to answer your question about and furthermore, the chemotherapy backbone given before surgery and after surgery is not that different if it's kind of if it was like kind of like a lower stage. If it's a higher stage, higher risk patient, then those are the patients where I really want to try to intensify their therapies if I think they're appropriate, because we really have one chance at trying to cure these patients. And so that's really should be the ultimate goal. Certainly it's, chemotherapy is tough. It's no cakewalk. And I try my best to explain that, the reasons why we would do this. And to your other point about surgery and morbidities from surgery, I think that doing neoadjuvant therapy increases the chances of having a smaller surgery. So potentially you're saving patients from additional surgical morbidity.
Okay, great. I have another question, and this is a post-pregnancy diagnosis versus young person diagnosis. There is a difference, isn't there?
So I think in both cases, young patients, I mean, I don't want to set an age limit there, but essentially we find that younger patients, certain racial subgroups and patients who are diagnosed with during pregnancy tend to have, generally more aggressive disease. At the same time, they more aggressive disease may be more chemotherapy sensitive. So I think if I get what you're asking, I think the way we treat them is more or less the same. We still try to give chemotherapy and after the second trimester we can give chemotherapy. I think the idea of do we have to break for treatment because someone is pregnant or breastfeeding. I think there are some limitations there, right? Like if someone's actively going through chemotherapy, they probably shouldn't be breastfeeding. I think the whole pregnancy discussion is also more relevant for estrogen hormone receptor positive disease, where patients are being recommended 5 to 10 years of anti-hormone therapy. So there's some data on that about doing that for a few years and then stopping to try to become pregnant if they're young and want to have a family. Whereas, I think it's really important, right? The other point is that if someone is of fertile age and want to expand their family, it is terribly important to discuss fertility prevention options. And that could include cryopreservation of their eggs and also administering ovarian suppression during chemotherapy, which has less evidence, but we still sometimes do it.
Okay, great. And can we speak a little bit about metastases in triple negative patients?
Yeah.
For other cancers, usually bone and liver, where does this travel to?
So the majority of triple negative breast cancers have the basal subtype, kind of like the bona fide aggressive triple negative breast cancer phenotype. And those patients tend to have propensity for lung and liver metastases and bone metastases too, for sure. And about 15 to 20% risk of brain metastases as well. There are potentially subtypes of triple negative breast cancers that may present with bone metastases only. But I don't think it's very clear cut. Yeah. So ultimately we wouldn't use kind of like.
But it is different, right, from the other
Yeah, I think the risk of having kind of metastases in the organs is much higher. Like that and HER2 positive. Hormone receptor positive, generally they start in the bones first.
So your presentation had a lot to do with the US studies. How does this compare with the Canadian population? Is there a difference, or are you just providing it because they do much more work in this?
So yeah. So some of them are US only studies. And certainly a large number of them are led by the US just because they have a larger population. But a lot of these trials are actually international collaborations that include Canada. So I apologize for maybe misquoting that. Yeah, so because triple negative breast cancer is a less common subtype, it requires a multinational effort oftentimes to conduct these practice-changing studies.
Okay, great. And one last question. How well knowledgeable are patients when you see them about triple negative breast cancer?
I think it really varies. I think, at least in Ottawa, a lot of patients tend to be well-informed and tend to be educated and have done some reading and can understand the broad strokes of the illness, that it can be a serious disease, and understand the need of treatment. But certainly it varies.
It varies. Okay.
Yeah, it varies for
There's a
sure.
lot of information. It's not
Yeah, no matter how prepared or
all
how
right.
well-read you may be, it's still overwhelming.
It is overwhelming because there's so much going on now with precision therapy and all kinds of therapies. It's different from the days of our mothers, I guess, a long time ago. So I have some questions that were submitted, and I will ask the first one. The patient asks, if you have surgery first and then chemoradiation with complete response, would immunotherapy be needed? It was not offered to me, so I'm curious. This is what one of the patients is asking.
Yeah, so if you had surgery up front without any prior treatment, we wouldn't be able to assess response because the tumor has been removed. So up to 2024, if you had triple negative breast cancer surgery up front, the standard of care would still be chemo followed by radiation.
Okay. And this one has a different treatment. If you had surgery first and then chemo with Taxol and carboplatin, 14 sessions, she says, and radiation, 12 sessions, how do you know if you will have a complete response? I guess, how do you know?
Yes. I mean, I get this question almost every day in clinic. Basically, oh, I apologize. That's my pager. Just answer it later. So essentially, we don't know, right? What I tell patients is that as far as we know, like all the cancer that we can see has been removed. And so we know based on the tumor and nodal stage what your approximate risk is and when we should give chemotherapy. And because on average, you're going to benefit from it. Like you'll live longer on average, and the chance of recurrence will be lower. And so we basically done everything that we can do. And therefore first of all, we don't have anything to measure, but also we wouldn't routinely do CT scans every 6 months to see if the cancer has come back, because that can be quite stressful for patients, and it doesn't change what we do.
Can I ask you another question? In terms of treatment plan, can you give me some percentage values of what the surgery does, what the chemotherapy does? Like if you have surgery alone, what's the percentage of it, being beneficial? If you have the chemo, like what are those percentages?
Yeah, I think surgery is still the most definitive treatment and it's the most important.
Yeah.
And then chemotherapy is buying insurance.
Yes.
Sometimes very expensive insurance that you may or may not cash out on, but you know that the stats are in your favor to get chemotherapy in some cases.
Okay.
So the risk, so I would say generally chemotherapy would reduce the risk by 30%. Like relative risk reduction, right? So if your starting risk was 30%, a 30% relative risk reduction would bring 30% down to 20%, that type of magnitude of benefit.
Right. So my next question from one of the audience member here. I was lucky to find my triple negative breast cancer early. I had a lumpectomy, no nodes involved. Do patients in this setting still benefit from chemotherapy? And what type of regime? Immunotherapy? Question.
I mean, that really depends on a number of factors. It depends how small it was. And it also depends on what subtype of triple negative breast cancer your oncologist thinks it is. If it was a bona fide high-grade triple negative breast cancer, generally if a tumor is more than 5 millimeters, chemotherapy would be considered. But as to the specific chemotherapy regimen, there are different ways to do it, and I wouldn't say this is the one for your situation.
Okay. And a question about ovary suppression. Is that something that is part of a treatment plan, and for whom would it benefit mostly?
Yeah, so mainly for fertility preservation, it's an option to add on if someone is young and fertile and really like realistically has a desire and an option to have children after chemotherapy. I think if one were a little bit older, I think the benefits may be less obvious. Ultimately, the best way to preserve fertility would be to meet with a fertility specialist to discuss options. But there is some data to suggest that giving Lupron injections once a month while the patient is on chemotherapy may reduce the risk of sorry. They didn't look at fertility per se, but ovarian function after chemotherapy is increased.
And what about ovarectomy to add on to layers of therapy for certain?
So for triple negative breast cancer, we don't do that. It's mainly reserved for hormone receptor positive disease.
And because it's not effective, or it's just
because triple negative breast cancer is not a hormone driven disease.
but the BRCA is.
So no, not all cases of BRCA mutated patients. Like, so if you have triple negative subtype, then your ovarian function doesn't increase your risk of cancer recurrence, only if you have estrogen receptor positive disease.
Okay. I have another question. I had sorry, I'm trying to read their question. I had a almost PCR less than 1%, RCR, decided not to have further treatment, weighing risks. Where does this leave me for my 5-year survival rate?
Yeah, so again, without actually seeing the pathology report, I can't really say with certainty, but if you had truly minimal disease to the point that it's almost like a PCR, then the data would say that 5-year survival is over 90% in PCR patients. So that would maybe very close to that.
Okay. There's a question that is not on therapy. It's about, well, it could be diet and exercise.
Yeah.
What about diet and exercise? Any research that?
Yeah. I'm not an expert in like the diet and exercise science, to be honest, but I've certainly come across plenty of literature where the title and abstracts are saying that if you exercise regularly, if you manage your body mass index, if you eat a specific way, like basically kind of like a diet rich with whole foods, that those generally are correlated with better health outcomes, possibly impacting breast cancer outcomes as well. But I don't think we have a definitive guideline for patients day to day.
And this would be just in the triple negative cancer?
No, I would say all breast cancer patients.
All breast cancer.
Yeah.
Okay. There's a lot of work being done in that as well, because yeah.
Very challenging field to study, but it's very important.
Yes. There's another question here. Did you come across any data for metaplastic breast cancer patients? It's the 1% of breast cancers that is also triple negative, and about 3/4 of the time. I'm sorry, if I'm not reading.
So metaplastic breast cancers are a rare subtype. Because they are so uncommon, it's really hard to do larger studies to kind of test whether a specific regimen is better for it or not. So routinely we discuss these cases in our tumor boards, and we still generally recommend the same types of chemotherapy treatments for these patients.
So I have a question also in terms of compliance to these drugs, medication. How good is it from patients that are undergoing these therapies? Do a lot of patients just give up, and what is the rate of compliance?
Yeah, so I think the breast cancer group or population tend, at least most of the ones that I've encountered, tend to be fairly determined with finishing their treatments. And when I try to reduce the dose or like stop them early, it's like, no, 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 I want to finish as much as possible because I want to live, for various reasons. So, but yeah, we do encounter occasional situations where an individual may be averse to treatments despite our strongest recommendations given their high risk situation, for example.
Well, that's good to know because with the oral therapies for HR positive, the compliance is really not that great. So
Yeah, yeah. At least here we know whether they got their IB treatments or not.
yeah. I have more questions from the audience. One of them is, if you have completed all treatment, can you ask for a circulating tumor DNA blood test?
So circulating tumor DNA is still considered in the research realm. There are companies that offer them privately, so you could pay for that out of pocket. I think it's an exciting technology, and I'm involved in some of the kind of investigator-initiated research. But I think at this point in time, it's still not quite ready for prime time for various reasons, right? Like, for example, like we don't really know what's the best thing to do if someone has a positive circulating tumor DNA. I don't think I would be comfortable committing to treatment again based on that result alone.
Yeah,
So there's a lot of things that need to be worked on before we can use that routinely.
it's nice to know a lot, but what do you do with it?
Yeah, yeah, it can be a double-edged sword for
Yeah.
sure.
Yes, yes. Uh, we're almost coming to the end of our time, not the questions. But can you confirm confirm that when you talk about relapse after 5 years, you mean 5 years from initial diagnosis versus 5 years from end of treatment? Is there a difference?
Yeah, I mean, I guess 5 years from the end of treatment would be a more stringent criteria because you have longer time period of observation. But I think 5 years from the time of surgery would be when I would use.
And is that accurate? Because you've probably had the tumor in there for how long prior to discovering, right?
Yeah, but the data that we're seeing is that like that's what they're using is like when they were diagnosed and had surgery. So that's what we have to go on.
Right. So we do have more questions, but we're coming to the end of things. So would you like to leave us with some comments? I would like to hear something about where are we in this, subset, and how fast do you think we're going to get to the almost finished line?
I think, I mean, if we reach the finish line, which I certainly hope for our patients, I would be out of a job. But that's just a joke. But I think that it'll be important to not be thinking about more and more therapy, which can be the case, but also looking at who can we avoid treatments in, right? Who can we avoid chemotherapy in? And I did allude to at least some studies that may be happening where we're looking at people with high tumor infiltrating lymphocytes who may be able to omit treatment. But that's kind of still in the research realm and definitely not something that I'm recommending today to patients, but it's something worth exploring. And I also think that it's really important for the community to be engaged in not only kind of the glamorous industry-sponsored research, but also investigator-initiated research that sometimes doesn't get done otherwise, that are equally important.
Thank you. Thank you. Thank you very much. So that concludes our time for today's session. I want to thank everyone for your questions, and I'm sorry we did not get to all of them, but that's a good thing. It's obviously a very hot topic for a lot of people, and for joining us to learn about recent advancements in the treatment and care and the research for triple-negative breast cancer. Thank you again, Dr. Ng, for being here with us. I know how busy you and others like yourself are, and this is really helpful to our patient population. I want to thank again our sponsors, Novartis, Gilead, and Pfizer. So just so we finish off with following this session, you will get a link to complete a survey to provide feedback on the session. Any feedback is welcome. This is how we improve our presentations moving forward, and perhaps to answer you questions that we're not, being able to ask at this session. Please consider leaving feedback at any time. And I'd like to thank everybody for joining us, and goodbye, everyone, and have a good afternoon.